due to the fact that the origin of the esophagus and the airway is common and acquired ones. In this paper from in 2015 of the group of Boston, there are the summary of the most common anomalies of the airway in esophageal atresia patients. And I think it's a good framework for our presentation. About the congenital, I told the foregut is the common origin of both esophagus and trachea that have different destinies, but at the origin they are the same tube. And only later they differentiate, and the esophagus will become predominantly muscular, and the trachea predominantly made of cartilage. So two organs were studied in very old time by these two scientists, who found already that in 68% of cases, the ratio between cartilage and pars membranacea in esophageal atresia patient was inferior to the normal 4.5 to 1. The cartilage of the trachea appears already at 7th week and is completed at 25th week of gestation, and the cartilage is getting more resistance with the time. The ratio between cartilage and pars membranacea is stable. The pars membranacea of the trachea is the muscular remnant of the trachea that can be considered like the remnant of the esophagus from which it takes origin. And also these muscles increase tone, dimension, and contractility. So the result is that during gestation, the trachea becomes more wide and steady. This was a paper that we published when I was in London, and I took it because there is a nice drawings about the components. So the red is the muscular component of, and the cartilage rings are the other component. And in the normal situation, there is a prevalence in the trachea. There is a prevalence of cartilage, and the muscle represented only in a small part posteriorly. In tracheomalacia, there is more abundance of muscular and deficient cartilage rings. This situation is extreme in absent cartilage rings. That was the topic of our work, our paper. It was a subject with esophageal atresia who didn't have any cartilage rings for a segment of the trachea, and the extreme pattern is the tracheal agenesis with the two bronchi taking origin from the muscular tube, something like esophagus. On the opposite side, the cartilage can be too represented and become 360 degrees, so the complete tracheal rings, and the pars membranacea is deficient, and the more rare cartilage sleeve. Coming back to our framework, we can see that there are two types of malacia described in association of esophageal atresia, but they are very different. Laryngomalacia, for the youngest, is divided in three types and corresponds to an anomalous softness of the aditus laryngeus, laryngeal aditus, and tends actually to improve spontaneously, and only rarely must be corrected, usually endoscopically. Tracheomalacia, this is a drawing took by the book of Philippe Monnier, and above there is the normal trachea, and below the tracheomalacia you can see the cartilage are flattened, and the pars membranacea is wider than normal. So during expiration, during the dynamics phase, the two walls tend to collapse. In the books, it's reported a spontaneous improvement also for tracheomalacia. I start to doubt about that. It's true that sometimes the symptoms become better in patients, but bronchoscopically, it's not only always true that tracheomalacia improves spontaneously, like laryngomalacia. This is the extreme of situation of tracheomalacia, absent rings. This is trachea without rings, and this segment of trachea can be considered like an esophagus, as you can see. And also OCT is a technology for detecting cartilage, and there is no cartilage here. Also, other groups, this is Cincinnati groups, describe the situation associated also with esophageal atresia. But speaking about tracheomalacia, esophagus, foregut, we don't have to forget the vascular structures. And there are different situations, all of them can be associated with esophageal atresia. So it's important to study every patient with esophageal atresia with echocardiography, and maybe we can change also the surgical approach sometimes, or we have to know that can be also subclavian artery aberrant in esophageal patient that can complicate so much the surgery. I don't want to speak about the treatment of tracheomalacia. There are other speakers who will do, but just to say that there are many options. And another situation is laryngeal cleft that is sometimes underestimated, but the group of Boston found that it was very commonly associated with esophageal atresia. This is a patient who was born with a cleft. You can see here the airway and posteriorly the esophagus, but the esophagus was with esophageal atresia, so there was the upper pouch that was completely open into the airway, and here you can see the esophageal pouch. This is a severe case, but less severe cleft are very commonly observed in esophageal atresia patient, and sometimes can justify dysphagia of the patients. Another patient we have observed recently, and Professor Leva, if is connected, knows her very well, is a congenital tracheal stenosis associated with an esophageal atresia patient. And this is not described by the group of Boston. And there are also different situations. This is a paper that Juan Tovar edited, and I was one of the reviewer, in which it was described a unique malformation of the foregut that they called esophageal trachea, but we could also call foregut persistence, because there is a tube like a foregut, not differentiated into the two organs. And this is yesterday, one of our colleague in Kazakhstan, where Professor Mattioli and I go sometimes to do some surgery, and they sent to me a video of a patient in which it was suspected like a fistula or a cleft, and this was the drawing made by them, not by me. Professor Lima. It's not, I'm not to be blamed this time. But this is the drawing of the fistula, like a double fistula. I don't know how to call this malformation. I don't know if there are some suggestions. And all these are not reported. Now we go into the vocal cord palsy. I don't know if we can see, hear the noise of the baby. He has a stridor. This is congenital vocal cord palsy that can be associated with esophageal atresia. But the same situation, vocal cord palsy, can be also an acquired condition in esophageal atresia patient. In particular, this is a patient operated by us in neonatal period some months ago with H fistula, so esophageal atresia type 5 or E. And we approach from the right neck. Here you can see the carotid artery. Here you can see the esophagus. Here you can see the trachea. And I don't know if you can see it. In the needle is indicating the recurrence nerve. And so we saw it very, very well, and we avoided it very, very carefully. But the patient remained with a vocal cord palsy bilateral for 10 days. Then it was resolved spontaneously, but we were very anxious about that. Okay. So another situation is subglottic stenosis associated with esophageal atresia in the acquired situation. Why? Because the tube that sometimes is not easy to remove from the patient, and they cannot wean by mechanical ventilation for tracheomalacia or for complication of the surgery, and the tube can press over the posterior part of the cricoid, and subglottic stenosis can occur. So sometimes the esophageal atresia patients are a summary of multiple airway pathology, like this patient, 20-year-old that we operated last year, who had vocal cord palsy, treated already in another center endoscopically, subglottic stenosis, result of multiple intubation, and tracheomalacia. This was the patient we had to plan a lot of surgery before for resolving subglottic stenosis, and then we performed treatment of tracheomalacia with posterior tracheopex. This is another patient who had esophageal atresia, and again, this is a smaller one, 3-year-old, and had a subglottic stenosis, not very severe, I would say second degree subglottic stenosis, but he had also quite severe tracheomalacia. You can see the distal trachea embedded with the secretions, and with the walls very collapsed in the anteroposterior sense. So in this case, we decided to treat both conditions at the same time. You can see here below the vocal cord, the subglottic stenosis in the same patient. So in this case, we performed, the cardiac surgeon performed orthopexy. You can see the aorta lifted up through a midline approach, manubrium sternotomy, only the manubrium, and we extended the incision cranially to treat also the subglottic stenosis with an anterior graft in the same time. So in conclusion, esophageal atresia patients often present with airway-related problems, and we really have to consider both esophageal and tracheal problems at the same times. And multidisciplinary teams are required to do that properly. Thank you very much.
Thank you very much, Michele, for your fine presentation. For the discussion, I think it's better to do the discussion after the presentation of Dr. Sacco. I remember all that I am recording the meeting, like all the meeting that we do with the Club 15, and it's possible to see the recording of the meeting in the website of Italian Society. It's possible tomorrow or Friday is possible to see the meeting. Now, Dr. Sacco, that works in Caslini, is pneumologist. You have many surgeons that listen you, Dr. Sacco, and we are very interested to know when this arrived the surgery for tracheomalacia. What is your opinion and your presentation? Thank you very much.
Thank you for this invitation. Probably I'm the only one not surgeon at this surgical meeting, and so I represent the other side of the moon. But I'm quite important because about my opinion is quite important to call a surgeon, to call Michele, to call Mattioli, Girolamo, and perform the I'm sorry. You can see my screen.
No, we don't see.
Not yet.
I'm sorry. You can see right now.
Yes, it's arrived. Perfect. This is your first. Okay.
I feel a little better. Thank you. So from the starting from, I'm sorry. Okay. So this is speaking about the central airways. Why are so important? They are so important because the mechanics of the central airway and their physiological patency in quiet breathing and coughing are an essential factor for the lung health and for fighting respiratory infection. And that is even more important in pediatric age, in children, because the central airways are more flexible and mobile than adults, and so they are more prone to the structural dynamic failure. The trachea, the windpipe, is surrounded in the mediastinum by vascular structure, and its lumen can be easily constricted by extrinsic compression in the pediatric age. Let me see how the trachea is kept open. The structure of the trachea has the structure of is like an arch bridge. In the arch bridge, the patency of a tracheal lumen is maintained by about 20 cartilaginous arch. The arch bridge has such a conformation that the load, the force applied on the top of the bridge is discharged along the side. This distribution of forces along the side is working as long as the arc structure is maintained. But sometimes when the arch is bended, the load of the bridge is no more discharged along the side, but remain at the center of the arch. And so a bended arch has no more the possibility to counter an extrinsic pressure, and it has the tendency to flex even more and more as long as this external force is applied. In this case, there is an artery, nominate artery, is pressing against the tracheal wall in its course from the left, from the aortic arch to right, and is hammering, is pulsing against the cartilaginous arch at every heartbeat. This one here is a CT scan, is showing the innominate artery, and this one and the endoscopic view. In this case, the structural wall, structure of the trachea is maintained. There is a good expression of a cartilaginous arch, but the innominate artery is fighting, is the winner against the trachea. And this one is an endoscopy, is a 4-year-old boy with a recurrent barking cough, and the endoscopy show light or medium extrinsic compression of the tracheal lumen. By its position, you can understand even without the CT scan view that is due to innominate artery, and the heartbeat can be assessed at every just endoscopically. And in this patient, the cartilaginous ring are well represented, so is secondary tracheal malacia. But the tracheal compression can inhibit mucociliary clearing and the driving force of cough, because the tracheal lumen tend to close during the cough. And so in this patient, it's quite easily to find a recurrent or persistent bronchial infection, as in this case had a prolonged bacterial bronchitis. In this case, it was due to Haemophilus influenza. In any case, the endoscopic view in quiet breathing do not completely explain, is not able to explain what's happened during coughing. This one is purulent mucus. For this reason, a good endoscopy do have to check and must evaluate the trachea, the tracheal lumen, not only during the quiet breathing, but even what is going on when the patient is coughing, like in this one. And in this one, you show how to stimulate. So we brush the endoscope against the carina and stimulate the cough reflex touching the carina with the endoscope. In fact, the cough reflex is present even if the patient is sedated, and the patient, of course, is not able to cough efficiently because you have a bronchoscope in the larynx, but he can do abdominal press and mimic the increasing pressure inside the thorax during the cough cycle. And during the cough cycle, you can see here the posterior membranaceous part of the trachea is start to bulging against inside the lumen in response. You can see here, and even more probably. You can see, wait a second, try to stimulate more. And is bulging inside the tracheal lumen, and this and can have a quite complete closure of the tracheal lumen at the level of the extrinsic tracheal compression, and this level here. This can happen because the tracheal wall is something like barred anteriously at the level of the tracheal extrinsic compression, and it cannot move forward, a little forward, in response to the protrusion of the pars membranacea. And as we said before, the clearance of the bronchial secretion is severely decreased as a consequence, and so something like that. And so this patient, from a clinical point of view, as producing a barking cough. Sometimes you can see barking cough or barking seal cough, because the seal, the marine mammal, cough in this way. And all the patient in tracheomalacia is showing such a kind of cough. In tracheomalacia, there is the tendency to collapse of the airway when the child exhale or cough. The collapsing windpipe makes difficult the clearance of secretion with consequent recurrent infections, as we said before. And the most common clinical symptoms is the presence of barking seal cough. Such a cough is characterized by a two-tone sound. One tone is generated by larynx, as in every one of us. The second tone, is pathological tone, is due to the malastic tracheal wall vibrating during coughing. And you have not to be surprised that this patient have generally two types of cough. A normal cough when they cough softly and the malastic tracheal wall do not vibrate. So one is physiological cough, and a barking pathological cough when it's blow harder and thus causes the wall of the trachea to vibrate and produce sound. And again, speak about clinical diagnosis. Such a kind of two-tone cough can be easily distinguished from the human ear because the harmonic of the sound, the vibration coming from the larynx and the sound generated by the tracheal wall are different. And so for us, for pulmonologists, and hopefully even for surgeons, the most important diagnostic procedure to be able to understand if you have a patient with tracheal malacia is simply to ask to the patient. We generally ask two questions. First, are you able to recognize that is your child who coughs even when he plays among his companions in the garden and the park? Or it seems to you that your child has a different cough tone from his peers, so it's quite different, it's particular, it's special. The other people without tracheomalacia will never be able to produce such a barking cough. After this question, very simple question, you can decide whether to proceed with the invasive diagnostic procedure, an endoscopy, CT scan, etc. And so tracheomalacia is diagnosed by walking down the street. For me, it's quite common experience to go along the street, down the street, and be able to recognize time to time barking cough produced by some children. And in this meeting, we have to speak about tracheoesophageal fistula. And in reality, in this patient, you have a very severe tracheomalacia just because you have primary plus secondary tracheal malacia. And Dr. Thore was speaking just before about that. The ratio about the cartilage and the muscular, the membranaceous posterior part is wrong. Because there is a persistent foregut influence on tracheal wall development, and this is inducing primary tracheal malacia. And so the cartilage are poor represented, the cartilaginous are poor represented at the fistula level. In any case, in this patient, the primary malacia due to tracheoesophageal fistula is at 90% of the case associated with a secondary malacia due to the concomitant severe extrinsic compression due to innominate artery, as you can see here. So one primary plus secondary malacia. And this patient can show really severe tracheal malacia and this patient was about 3 or 4 months old patient, and the tracheal lumen closed almost completely here. You can see the heart beating due to the innominate artery severe extensive compression. And this one is the tracheal fistula. It was repaired, but was not repaired, of course, the tracheomalacia. In this case, you don't have any question, any choice to perform orthopexy. And in this case, was a patient with tracheoesophageal fistula with severe tracheomalacia. This one was CT scan at 6 months of age. This one is very small, so the tracheal lumen is could be bigger, but has been very compressed. This one is a large thymus, absolutely physiological at this age of a patient. And this one is the endoscopic view, and we perform orthopexy. In this case, it's much better, as Michele Torres said before, to perform orthopexy with an anterior sternotomy of the manubrium of the sternum, just because so you can get rid almost complete of the thymus, and you have much more space in front toward the sternum to perform a nice orthopexy. It is much better than a left parasternal access. And so without the thymus, the aortic arch can be tractionated easily more anteriously, and the innominate artery is much better pushed toward the sternum, away from trachea. And this one is CT scan performed 1 year later after the orthopexy with quite a good result about the tracheal lumen. During the orthopexy, is a great important that the tracheal lumen has to be monitored by intraoperatory endoscopy through the orotracheal tube. You can see this one is the orotracheal tube, and this one was the site of the previous extrinsic compression. In this case, the thymectomy has been just performed. There is no more visible the arterial pulsation against the tracheal wall. And during the orthopexy, we check the tracheal lumen, and the surgeon is performing a nice traction toward the sternum of the aortic arch. You can see exactly, you can see here a nice dilation of the tracheal lumen. So traction, and after release, probably you can see here traction and release. You can see how much the tracheal lumen is changing, and again they perform again. And such a kind of endoscopic view intraoperatory can really be helpful for the surgical treatment for the traction. You can help the surgeon to exert the traction in the right direction to have the best result in trachea. And in any case, this one is another patient with a barking cough. This one was about 6 or 7 years old. CT scan 2016. You can see quite a mild compression over the trachea and quite breathing, much more during the cough. This one is the thymus. And an orthopexy plus thymectomy was performed. And this one is a control CT scan performed 4 years after the orthopexy. Why we perform such a CT scan? To check if everything was going well, because the patient was not improving about barking cough. He was keep going, barking cough quite loudly with our discomfort. And what's the reason why such a clinical sign was still keep going, even if the surgical treatment was completely correct? The reason is in this endoscopic view. The tracheal lumen was quite open in quiet breathing, but when the patient was coughing, was appearing a tremendous bulging of a posterior membranaceous tracheal wall. So exaggerated that the tracheal lumen was almost completely obliterated. You can see here, tracheal lumen is moving, is not completely, try to cough, you can see completely occlusion of a tracheal lumen. And this one is absolutely pathologic view. In fact, every one of us, when we cough, show a physiological bulging of the membranaceous, posterior membranaceous part of the trachea. But such bulging don't have to be too much, so exaggerated, because if it's such a great movement, you can see a pathological bulging with the closure of a tracheal lumen. The patient is having a barking cough, and so such a kind of excessive bulging of posterior tracheal wall is called excessive dynamics airway collapse. And in this case, the reason of the closure is not due to a extrinsic anterior innominate artery or another arterial trunk compression, but the excessive movement of the membranaceous part. And so we need to perform not anterior orthopexy, but posterior tracheopexy. And they can see from the program, orthopexy versus tracheopexy will be the item of Professor David Van Zee, and so I can see nothing else. But I can show you something. This one is my vegetable garden in the country. Is my very good and nice nice hobby. Thanks for your attention.
Thanks, Professor Sacco, for your presentation. And now I start the discussion. Please, from the audience, there is question, is comments. David, you have a comments? Hadrian?
I will try to give my view in my presentation, which comes later on. Okay. But it is more or less in line with what has been stated till now.
Thank you. Patricio?
Oh, thanks, Dr. Lima. Congratulations to the speakers. And I would like to ask Michele, what did you find in that biopsy of the patient with rings at Genesis? And you did present in your slides. So there was absence of cartilage, or there was a remnant of cartilage?
It was a patient operated in London.
Yeah.
And the segment of the trachea was without any cartilage, only pars membranacea. And it looks like in some way like the patient presented in the paper that I shown before, but in this paper there was absence of the two different tubes, and while in this patient there was like a piece of esophagus inserted into the trachea. I don't know. I think we should maybe change some classification, because there are so different situations that are without names. I don't know how to call some conditions. I don't know. What do you think?
Thanks. Yeah, I agree.
Hadrian, you have a comment about?
No, I will speak after my little talk. Thank you.
Oh, yes. Hadrian, like David, you attend your presentation for speak about this. Okay.
I reserve my comments for so far.
Oh, yes. Okay. Thank you very much. Now, Professor Varela, speak about the recurrence tracheoesophageal fistula. This is a problem that is very difficult to sleep before the night of the operation and the night after the operation for all pediatric surgeons. Please, Professor Varela, if you want to start your presentation. Thank you very much.
Thank you. Let me share my screen again. Just a minute. Okay. Again, can you see my full screen?
Yes, yes. Perfect. Thank you.
Thank you. Let me. Okay, wait. Just a second. Okay, let's start. I will take 20 minutes. Thanks, Professor Mario Lima and Girolamo, for the invitation. It's a pleasure to be with all of you today. I would also like to thank the organizer of the meeting for giving me once again the opportunity to share my experience in airway surgery. The endoscopic treatment of recurrent tracheoesophageal fistula is actually one of my favorite topics. Sometimes it's a nightmare, like Professor Lima just commented. This is a view of Santiago de Chile during the winter time. The city is very close to the Andes. We have a lot of snow from June to September, so the winter season is coming soon. I work in two places, in a public children's hospital and in Clínica Las Condes Medical Center, where I do my private practice. Both centers have joined with the University of Chile, and we have in both an airway training program. Introduction. There are several types of tracheoesophageal fistulas. You know all of this. Some are congenital, associated to esophageal atresia, H-type fistulas without atresia, cleft, and anomalous communication between esophagus and bronchus in the tracheal agenesis. Others are acquired to foreign bodies, batteries, long tracheal intubation with cuff, and recurrent fistulas after esophageal atresia repair. This is the classical esophageal atresia classification. Type 3 is the most frequent type. The others are very infrequent, especially type 2 and type 4, the only one with 2 fistulas. In the type 3 esophageal atresia, fistula is localized more frequently 1 to 2 rings above the carina. We do scope all the patients before to repair an esophageal atresia. It's not rare to see the fistula in the carina, just in between both bronchus, or even distally. This information is useful for the surgeon in the operating room, and it is an important finding in order to delay an anastomosis without tension to a second stage after the fistula is closed. As I mentioned it before, type 2 and type 4 are very infrequent to see. Type 4, the only one with 2 fistulas. Type 1, this is a type 2. Fistula was found during the esophageal anastomosis performed, as you see, by thoracoscopic approach. As you can see, there is a fistula between the upper esophageal pouch and trachea. The previous diagnosis was a type 1, means esophageal atresia without any fistula. During the laryngoscopy, the fistula was overlooked, and finally, it was found during the dissection in the thoracoscopy, as you can see in this nice video. Here is an example of a congenital H-type fistula. Most of them are localized in the neck, and the treatment is open repair. But sometimes we approach it with a thoracoscopy. H-type fistula, just a second. H-type fistula is not always easily seen. Frequently, it is a tiny hole and can be easily overlooked. When diagnosis is suspected, the best study to identify the fistula is esophageal contrast study and airway endoscopy. Usually, the fistula is located in the cervical region or in the thoracic inlet. Less frequently are located at the chest level. Our standard treatment for the H-type fistula is an open approach. We approach the neck by the right side, but sometimes by the left side, as suggested by Jennings from Boston. A guide wire introduced into the fistula is useful in order to find the fistula tract during the dissection. We can also do an endoscopy to see the wire into the esophagus. In few cases, just few cases, we have approached the fistula through thoracoscopy with the clip and go technique introduced by my friend Godoy in Chile. Regarding acquired fistulas, I was invited a couple of years ago to La Paz in Bolivia to treat 2 patients with an acquired tracheoesophageal fistula. As you know, La Paz city is located at 3,600 meters over the sea level, and the airport called El Alto at 4,000 meters over the sea. Behind, at the end, on the sky, you can see the nice Illimani Mount, one of the highest points in the Andes. In that city, in La Paz, I had the opportunity to treat these 2 patients, both with the same history of brain trauma and long intubation with insufflated cuff. And later, both have had frequent aspiration during oral feeding. This is one of the dramatic cases from La Paz in Bolivia. Below the vocal cords, there is a mild tracheal stenosis, and below it, a huge communication between the airway and esophagus. So the insufflated cuff produced an ischemia and necrosis of the tracheal and esophageal wall. I did repair through the neck. I did a tracheal resection and esophageal closure in 2 layers. A second case I did repair at the same time in Bolivia, a 19-year-old boy with a huge fistula after long tracheal intubation with an insufflated cuff. The repair was performed through the neck. I did a tracheal resection, end-to-end anastomosis, and esophageal closure in 2 layers. All the tracheal rings around the fistula were removed. This is my team at the Children's Hospital. They are my friends. We are a reference center in a country with a 17 million population, small country. We receive complex cases from all the country. Philippe Monnier, who is in the picture, has been an amazing support to our group since more than 10 years. And this is also my team. So I have many teams. They are all pediatric surgeons from Las Condes Medical Center. Again, type 3 is the most frequent type. The others are very infrequent. I would like to talk longer about all type of fistulas. It's one of my favorite topic, but I will focus on the recurrent tracheoesophageal fistulas after esophageal atresia repair. Surgical treatment for the type 3 considers fistula closure and primary esophageal anastomosis during the first days of life. Recurrent tracheoesophageal fistula is a complication seen in 3 to 15% of children undergoing esophageal atresia repair. We call recurrent fistula when there is a new communication between the esophageal anastomosis and the original fistula site in the trachea, the pouch. The surgical treatment or the surgical management of the recurrent tracheoesophageal fistula through a thoracotomy approach is very complex, with a high rate of second recurrence up to 22%. The standard approach has been for a long time a right redo thoracotomy, which has a high morbidity rate. He is a 7-year-old patient who has had 8 surgical procedures through a thoracotomy trying to close a recurrent fistula. In the last 3-4 years, I have seen 3 cases like this with more than 6 thoracotomies. Therefore, it seems reasonable to propose alternative treatments, and several endoscopic alternatives through the esophagus and trachea have been proposed, mainly esophageal approaches, using fibrin glue, sclerosis, laser stents, argon, T-cell, histocril, and others. Several reports in the literature demonstrated a high rate of failure, mainly esophageal approaches. This is a failed argon ablation through esophageal approach in a patient sorry, this is again, let me try again. This is a failed argon ablation through esophageal approach. In a patient I met time ago, argon was tried several times and esophageal stent was placed for a long time, but finally failed. However, in 2008, 3 ENTs from Korea reported the endoscopic management of recurrent tracheoesophageal fistula treated by tracheoscopic approach using chemocauterization with trichloroacetic acid. They reported 3 patients with a success of 100% after 3.3 TCA applications. After this report, 10 years ago, more than 10 years ago, we started doing the procedure in our center. This is our data between 2009 and 2021. We have treated 31 patients, 24 with a recurrent fistulas after type 3 esophageal atresia repair, and also 7 more patients with different type of secondary fistulas. The follow-up is 61 months. Fistula can be demonstrated in different ways. This is an X-ray study from one of our patients that shows contrast in the airway. The esophageal water instillation is our favorite approach to confirm the presence of a recurrent fistula. We don't use methylene blue, and we used to start with air insufflation and in the esophagus followed by water. And if we see bubbles or water in the tracheoscopic view, it means 100% that the fistula is open. How I do it? We used to place again a tracheal tube with the cuff insufflated in the proximal esophagus. This is the way we used to confirm if the fistula is open. Again, we put the tube in the esophagus, and in the tracheal view, first we see bubbles coming from the esophagus and then water across the fistula. We can also demonstrate an open fistula in this way, filling the esophagus with water. Then you ask to the anesthesiologist to ventilate the patient, and as you can see, air is coming from the trachea to the esophagus. If we confirm an open fistula, we proceed with the sealing. The mucosa into the fistula is partially removed using an endoscopic brush, and then a TCA 50% solution is applied. We use the TCA in solution or ointment. Let's see step by step. First step, the mucosa is removed using a small endoscopy brush. I think this is an important maneuver for the action of acid. After the mucosa is removed, a small piece of cotton with TCA is applied into the fistula, into the pouch. Sometimes we leave the cotton into the fistula or into the pouch for 1 or 2 minutes. And this is an endoscopic view just after the TCA applied. The white areas in the mucosa are superficial burns that heal spontaneously. The real sclerosis occurs in the fistula tract. Somebody
Per favore, Nino Marino, stacchi. Okay, please work, excuse me.
No, again. So as I said, yes. The white areas in the mucosa are superficial burns that heal spontaneously, and the real sclerosis occurs in the fistula tract, where the acid is applied hard and several times. This is an amazing video, courtesy of my friend Jaime Penchina, a surgeon from Mexico. He sent me this video from the first patient treated by TCA in his country. We can see a huge pouch with an open fistula at the end. And he did the procedure exactly like we do, starting with the brush, following by the TCA application. In this case, the fistula was closed after 1 TCA procedure. It is very important to place the tip of the bronchoscope just into the pouch to avoid spilling acid in other areas in the airway. This is another patient from my friend Penchina, again from Mexico, an amazing case with a huge fistula. The boy had 6 previous thoracotomies trying to close the fistula by open approach. You can even pass from the trachea to the esophagus with the scope. And 2 months later, the result is amazing. The fistula is completely closed and the tracheal mucosa absolutely healed. You can see a tiny border of the pouch in the upper trachea. And this is a 7-year-old boy that I have treated with my friend Diana Romero in Colombia with a secondary fistula between the left main bronchus and esophagus, secondary to a tuberculosis infection. It was sealed after 1 TCA application. This is how we do the procedure. It is very easy if you have everything set in the OR. We grasp the cotton with the TCA using a foreign body instrument. The patient is under ventilation using a rigid bronchoscope. And this is the maneuver. We are going into the pouch. Then we are going in to the pouch and rotating several times. Actually, we have modified the technique. TCA is applied in the brush, and the brush is introduced through the bronchoscope channel directly into the pouch. It's a safer technique. Here you can see the white color to the left in the mucosa after TCA is applied. I will show one more case, 2 more minutes. She's a 9-year-old, underwent a esophageal atresia repair when she was born. She looks very healthy, but she have had many respiratory infections during all her life. X-ray found a recurrent tracheoesophageal fistula. We took her into the OR. We can see the distal pouch from the original fistula. We put air in the esophagus, and bubbles confirm that the fistula is open, as we knew because we had the X-ray study. We scope it again, and what we see here is another fistula in the upper trachea, because this is the distal one, 2 rings above the carina. So this distal one is a recurrent fistula. And again, this is a proximal one. So this proximal one is a missed congenital fistula. And let's see if it's open. We irrigate water in the esophagus and is absolutely open. So finally, this patient was born with a type 4 esophageal atresia, not type 3. The distal fistula we found in the scope was a recurrent, and the proximal high in the trachea is a missed congenital type. We follow with TCA application in both fistulas, starting with the endoscopy brush. The recurrent distal sealed after 2 TCA application. However, the proximal remained open after 2 TCA, and finally we decided an open surgery by the neck. 4 years ago, we published our experience, and these are our results. This is the last slide, or just one more one. 24 patients with a recurrent fistula. In 9 of them, the fistula closed after 1 TCA application. 8 patients needed 2 TCA procedures, and in 4, the acid was applied 4 times. In the patient with a type 4, the distal fistula closer and the missed fistula was repaired by open approach. In 2, we could not close the fistula, and the last patient is still on treatment. Final comments: tracheoscopic chemocatheterization for recurrent tracheosophageal fistula seems to be safe and less invasive than a thoracotomy, of course. We have had success closure with 1 to 4 applications. Mean is 2.8. If we compare our result with the previous published series, the application from the trachea seems to be more effective than from the esophagus. Thanks to all for their attention.
Thank you very much, Professor Varela, for your fine presentation. It's very interesting. Also, I have experience of the use of TCA, and really, in sometimes is a very good solution. I open the discussion for this presentation. There is a question from the, David, please.
Thank you very much. Very nice presentation. Do you always use a rigid tracheoscope to look for your fistulae? Because sometimes people say that they can see it with a flexible laryngoscope, but I think you should really use the rigid tracheoscope.
Yeah, thanks, David, for the comment. I think you have seen these movies many times, my presentation, but it is some modifications. Yeah, we use the rigid scope, but today the flexible ones, the video endoscopy flexible scopes has a very high quality in view. So it doesn't matter if you want to use a flexible video endoscopy or a rigid one, but I use the rigid scope, really.
Particularly, if you want to look for the proximal fistula, you sometimes have to brush over the posterior wall in order to pull it open, and you can do that with your flexible scope. Yeah,
agree. Yeah, that's a tip. But if you really want to find an upper fistula in a grade 4 or grade or type 4 or type 2 esophageal atresia, you have to keep in mind the possibility to find another fistula, because it's very easy to overlook it, as you know, because the fistula in the type 2 esophageal atresia or the fistula in the type 4 esophageal atresia almost is a very tiny cleft in the upper part. If you have secretions, you cannot see the fistula. That's why many many of these cases have been overlooked for a long time. And now we're finding more type 2 and more type 4, more than before. So I have seen many type 4 and type 2, not many, but some of them in the last 3-4 years, because I have in my mind and I'm going directly to see if there is something there.
I agree, because I think in almost 50% of our cases of long gaps, we'll find an upper pouch fistula.
That's very interesting.
There is any question, other question for the audience?
I like to have a question for Patricia Varela. I really enjoy your presentation, and I generally use, I 100% use flexible bronchoscope, but and I like so much to perform the endoscopic closure of the fistula with trichloroacetic acid using flexible bronchoscope. But how you can get the trichloroacetic acid inside the working channel of the flexible bronchoscope? So it's a technical point of view how you can get, because it's not such a pleasant liquid, pleasant material, trichloroacetic acid.
Yeah. No, I suggest to use the acid like we do, using a foreign body instrument in a rigid bronchoscope, or using the brush with the ointment with acid. I do not suggest to do it through the channel in the flexible bronchoscope, because it's not precise. You have to use a small count of acid, very few, less than 0.1 cc. So I had a patient with a very bad burn with acid. It was transferred to my hospital last year with a huge burn in the posterior wall because the acid was spilling. It was an accident, and they were trying to put the acid through the channel using a flexible bronchoscope. So they put a catheter in the channel, and they push the syringe with the 3 cc of acid into the trachea, and there was a bad accident, and really it was a very bad case. So all the trachea was destroyed. So that's why I use the bronchoscope, the rigid one. I use a small count of acid, very few. So I put a little bit in the cotton or a little bit in the brush. And today I'm using ointment, and I have had 0 accidents in my experience. So the other patient, it was coming from another place, and it was an accident.
You have some very nice brushes where you have the sleeve that goes over the brush, and you introduce it right up to the fistula, and then you withdraw the sleeve before pushing the brush in.
Thank you very much. Other questions for the audience?
I have one.
Ernesto, please.
Yes, Dr. Varela, thank you very much. And I have 2 short questions for you. The first one is regarding the H-type fistula. You've got the largest, I think, the largest experience in the world. Do you have any landmark to decide how to approach the fistula? Because every time I face with this problem, if I decide to approach thoracoscopic, I realized I was too low. And if I decide to approach from the neck, I decided it was too high. So do you have any landmark? And the second question is for recurrent fistula. Do you have an explanation why we have recurrent fistula? Is due to the material? Is due to the technique we use? Which is your opinion about the recurrent fistula?
Okay, let me start with why we do still have recurrent fistula. I really don't know. We are a small country, 17 million population. We have at least 40, 45 new esophageal atresia per year, just 40, 45 in my country. Maybe in Italy you have, I don't know, maybe, I don't know, 200 per year. And if it's recurrent fistula is 10%, 3 to 15%, so 10%. So that means 3-4 cases per year in my country, and we are receiving 3 to 4 cases per year in my hospital. So all the surgeons are sending the recurrent tracheoesophageal fistula. They don't want to open the chest, and that's good for the patient. So it's very rare today to open the chest to try to close the fistula. And why is still a complication? I don't know, but when I do an open repair of tracheoesophageal fistula in esophageal atresia, I always put something in between. So I put periosteum from somewhere, or I put pleura, or I put muscle, any tissue. I think that most of the surgeons, they don't do that, but probably there are many factors. So I don't have probably some of you can make some comment about this topic, but we still see 10%. And regarding the H-type fistula, now the best way to evaluate if we are going to the neck or if we are going to try by the chest is in our hands, in my mind, is the endoscopy, flexible or rigid. I do always do rigid and flexible in all of my patients. So I have both in the OR. And so most of the H-type are in the neck. In the neck means in the first ring, 4 or even 5. So you can go by the neck, probably in almost 100% of the fistulas. H-type or type 4 or type 2. And but sometimes you can go to through the chest. And I use the scope. So if I see a fistula in the 7th ring or in the chest, I can go to the chest. But anyway, Ernesto, and because I have some very enthusiastic friends who likes to do this thoracoscopic, and they go to the neck by the chest. So you can take a piece of thyroid gland by the chest, and you can get some of the thymus from the chest. So if you have a fistula on the neck, you can go by thoracoscopically too. But I'm not agree with that. I think that the way for the fistulas in the neck, the best way is an open approach by the right or by the left. Thoracoscopic approach is just in very few cases, and I have seen maybe 1 or 2 candidates for that approach. And it's an amazing approach for a low fistulas. But it's very easy, very difficult to find a patient with a H-type fistula really in the chest. I don't know if you agree with that comment, and which one is your experience about that?
No, I agree with you. We managed 6 cases till now, and 5 of them we approached with the thoracoscopy, but it was always a chaos. And the one I approached from the neck, I was unhappy to approach from the neck. So I don't know what to do. I would love to have you here.
Yeah.
Question from, excuse me.
May I comment?
Yes, Adrian, one moment. There is a question from Girolamo, and after Adrian Bianchi, please.
Yes, you said that the primary fistula, you fail if you treat it with acid. Can you explain the difference between the 2 fistulas and why you need the surgery for the primary one and chemical approach for the second one?
Gracias, Girolamo. Are you talking about the case with the type 4?
Primary fistula or secondary fistula? Why you treat primary surgically and why you treat secondary or recurrence?
Okay. So we had this nice discussion with David Van der Zee in Boston last year, I thought. Yeah, it was February last year. Okay, we have the H-type fistula, a congenital one. Nobody touched it. And we have the recurrence one. So the recurrence one is inflammatory tissue, and the acid acts very well, and because we have the result. So most of the recurrent will be treated in the right way with the acid. I suggest that because it's an inflammatory tissue. And why I don't approach the congenital ones with acid? Because I did try at the beginning, and some of my friends did try. And H-type fistula is, you have all the layers, you have all the mucosa and the serosa and the muscle. So it's a different one. And probably that's the reason why they don't respond like the recurrent one. So we did fail, and we did not are doing anymore the H-type by endoscopic approach. We just go by the neck. It's an amazing surgery. I like to do that, and the result will be, in the most of the case, 100% success. So that's my response, Girolamo. I did fail, and I did fail means that I did, in one of that fistulas, I did 2 times with acid. And when I came back for the third time, the fistula, the H-type, was absolutely open, but absolutely open. Different when I try many times with the recurrent, because you see that the fistula is smaller and smaller and smaller. And that's why I have some patients with 4 applications in recurrent one. But for the congenital ones, my approach is open.
Thank you, Patricio. And now, Adrian, your comment?
Okay, I just want to agree absolutely with Patricio on what he said previously and also repeated now. I don't have a great experience, but from the little bit that I have seen over my working life, the H-type fistula is beautiful to approach through the right neck. If you do a clean dissection, you don't damage anything, you find the track, and you can ligate it and divide it. And I think it's not sensible to try getting at it from the chest. The recurrent fistula through a thoracotomy, again, I agree with you, Patricio. If you are going to do a recurrent one, you need to interpose some tissue between your trachea and your esophagus at the site of the fistulas. Not enough to just put sutures on both sides. It will recur. And if possible, you need also to try to separate the two. Now, you can do that by hitching the esophagus to one side as far as possible, but better is to put something in between. But what the point I want to make is that the best thing to put is something that is alive. So I don't like pleura or pericardium or such like. I prefer to use an intercostal muscle flap. You can raise a flap of intercostal muscle with its blood supply, and you just bring it along and put it in between. And that is live tissue that is going to stimulate good healing. So this was just a comment to supplement what you have been saying. I agree with a lot of what you have said. I have never had experience with the chemical approach. It would terrify me. But looking at you, I am a little bit more convinced that I would try maybe. Thank you.
Thank you. Thank you.
Maybe I may comment. I think we discussed this issue as well in Boston. This was 2 years ago. When you go back, at least thoracoscopically, for a recurrent fistula, when you have divided them both, if you put a hitch from the posterior wall just near the fistula and hitch it to the prevertebral fascia, you move it far away actually from where you have your wound in the esophagus. And this is also a very nice way to prevent recurrences, further recurrences.
Yeah, absolutely agree.
Thank you very much for this very nice discussion. It's very interesting. And now to speak, David van der Zee. The presentation, the title is Tracheomalacia, Aortopessis versus Tracheopessis. This is a amletic dub.
Thank you, Mario, for this nice introduction. I would like to share my screen. Can everyone see it now?
Yes, we start to see. Is arrived your slides, please.
Okay. So I've been asked to talk about tracheomalacia, surgical management, aortopexy versus tracheopexy. I have nothing to disclose. So in the past, tracheomalacia was always considered a separate entity that may result in acute life-threatening events. And aortopexy has become a generally accepted mode of treatment, although the impact of a thoracotomy is considerable. With the advent of minimal invasive surgery, the impact of such a procedure may be greatly reduced. So this is an example of where you see malformed tracheal rings. Here on one side, more malformed. So these are examples of malformed rings due to causing the tracheomalacia and the collapse of the tracheal rings. Now, the thoracoscopic approach is from the left side. Here you see a nice overview, collapsed lung, the phrenic nerve, the thymus. And you start with opening of the pleura, mobilization of the thymus. Some people reject the thymus, but we merely mobilize it and push it away to the right, so we get access to the aortic arch. And that is what you see over here. And then what we use is this very sharp riveting needle. So we make a small 2 millimeter stab incision over the sternum. And with this very sharp riveting needle, we can introduce the suture. And after withdrawing the needle, you can the riveting needle, you can introduce the needle itself. Take a hitch starting from the brachiocephalic artery down to the pericardium. And through the same small cutaneous incision, but then alongside the sternum, you can retrieve the suture and lead it outside again. And by doing so, here you see 3 sutures being placed. And then we introduce the flexible bronchoscope to see what is going to happen if we are going to lift up the aortic arch. And here you see the light of the bronchoscope. And this is when you have pulled up the sutures and you can tie them subcutaneously on the sternum. And this is what it looks like from outside. Here you see the 3 little stab wounds, the sutures that you pull up. Here you see the introduction of the 5 millimeter endoscope to 3 millimeter port for manipulation. Now, it has been mentioned already before in the first presentation that both the esophagus and trachea, they derive from the same primitive foregut. So if something goes wrong with the esophagus, it's most likely that also something may go wrong with the trachea. There was a nice publication on laryngeal tracheal abnormalities in Esophageal Atresia patients, a hidden entity, it was called. And although Rome is a center of expertise, 40% of all their patients with Esophageal Atresia also had laryngeal tracheal abnormalities. And 23% of these patients ended up with tracheostomy. So it is very impressive. And this brings us to the crux. Prior to any treatment of Esophageal Atresia, we perform a rigid tracheobronchoscopy. And we score the trachea on 3 different levels and right up into the main bronchi. And you have to score for, is it normal? Is there an anterior collapse due to the tracheal rings abnormalities? Or is there a posterior intrusion? Or is it both, which is also very important to acknowledge. And then, of course, you look for your proximal and distal fistula. So this is important nowadays, because for people who are not experienced in dealing with types of Esophageal Atresia that have a fistula ending up in at the level of the bronchi, you may have to stop your procedure and refer the patient to an expertise center. So now focusing on the posterior intrusion. Normally the pars membranosa is about 1/3 of the circumference, but in tracheomalacia, this can be up to 50% or more. So more recently, the posterior tracheopaxy against the prevertebral fascia has been described. And in this case, through a right thoracoscopy, the esophagus is mobilized from the trachea in the same way esophageal atresia would be approached. And we published this earlier. So here is an example of a posterior intrusion. You see it's an almost complete collapse, and you can imagine that this will cause severe problems. So under spontaneous breathing, in particular, the pars membranosa is floppy and causes the obstruction. And here you see, again, through a right thoracoscopy, remobilization of the esophagus. Here is the vagal nerve, is the posterior aspect of the trachea. And by mobilizing it, you see it's a patient that we got from somewhere else. The sutures are still present, and there's still a little remnant of the fistula present there. But by mobilizing the two ends, you can get free access to the posterior membrane, and then under direct control through a flexible bronchoscope through the tube, you can see exactly where you need to place your suture. And then you don't do a through and through suture, but just grab the wall and tie it against the prevertebral fascia. You take a second hitch and tie it, in this case even a third suture, and tie it to the prevertebral fascia. And this is then the postoperative view through the tube, that you see a clear opening now of the trachea. But this is a technically difficult reoperation. You have to dissect the whole esophagus and trachea again. So why not, when you perform your preoperative tracheoscopy before doing your esophageal atresia repair, and then see whether there is a considerable amount of posterior intrusion, why not put in these sutures before you make your anastomosis for the esophagus? So again, preoperatively, you do a very substantial scoring of the trachea. You look for posterior intrusion, and then you can consider before, after mobilization of the two ends of the esophagus, before making your anastomosis, to put in two sutures in the posterior membrane. So here you see a view from the preoperative tracheoscopy. Here's the fistula, and here, just above the fistula, you see a real protrusion of almost 50% of the posterior wall. So then, after mobilization of the proximal and distal esophagus, you put in 2 or 3 sutures, depending on the extent of the malformation, the malacia. But you do it again under direct flexible bronchoscopy through the tube. You put the sutures in and tie it against the prevertebral fascia. Here you see the proximal pouch, here you see the distal pouch. And now you open up your esophagus and you finish off your anastomosis. And this is the postoperative view. You see there is still some movement in the posterior wall, but it cannot collapse anymore. So we looked into our patients. We started in 2017 using this primary technique. We had 38 consecutive esophageal atresia patients, and 40 of them had a primary posterior tracheotomy. If you look into the patient characteristics, they're actually, well, similar to that you would see in other cases of esophageal atresia. Timing of surgery, the tracheal obstruction, the mean tracheal obstruction was about 45%. It depended between 20 and 90%. Now, this 20% is not much, but in these patients, we decided not to do a posterior tracheotomy. But after taking down the distal fistula, all of a sudden, this posterior membrane was going up and down, and there was a huge increase of collapse. So we decided in these two patients to reconsider and still do a posterior tracheotomy in these patients. Again, postoperative ventilation state, time in NICU, etc., is similar. So when we compare then the two groups before starting on the primary posterior tracheotomy and before, so between 2014 and 2016, before the time we had 39% of patients that had bruised, which is brief, resolved, and explained events. And after we started doing the primary repairs, we only found bruise in 19%. But also very interesting was that the amount of respiratory tract infections requiring antibiotics in this group before starting the primary was 61%. And after starting the primary repair, it was only 25% that had primary tract infections requiring antibiotics. So then looking down into this group where we did no PPTs, in those that did PPT, you can see that apparently it's the posterior membrane that is one of the major causes for causing respiratory tract infections. And by fixing this posterior membrane, we have decreased the amount of respiratory tract infections considerably. So I think this is another advantage for using this technique. So in conclusion, primary posterior tracheotomy during a thoracoscopic esophageal atresia repair is a new treatment for tracheomalacia in esophageal atresia patients. It can prevent a second, sometimes complex surgical procedure, and it prevents life-threatening respiratory symptoms of tracheomalacia and significantly reduces the upper airway infections. So primary posterior tracheotomy during thoracoscopic esophageal atresia repair is now the preferred approach in patients with tracheomalacia. And in most cases, there is no need for orthopexy in spite of additional collapse of tracheal rings. And only if symptoms persist on a later stage, an additional secondary thoracoscopic orthopexy may be considered. Thank you. It's open for discussion.
Thank you very much, David, for your wonderful presentation. I open the discussion to the audience. Girolamo.
Thank you, David. Very impressive, your experience and your numbers. My question is, during a neonatal procedure, primary procedure, a 2 kilogram infant, neonate, how can you be sure that you don't pass your suture through the mucosa? So the risk of a hole in the tracheal wall.
Yeah, I agree. If you have a small infant, it's being a more delicate procedure. But using the flexible bronchoscope inside your tube, you can see what you are doing. And by hitching into the posterior membrane, you can see that you can hitch it adequately, that it will hold, but not go through and through. So you can very carefully maneuver the needle through this posterior membrane without going through and through.
Posso, Mario? Posso?
Certo, certo, sì.
I attended your OR and I know exactly how you work, but I am impressed about a neonate with an endoscope inside the trachea tube and you are working in. So I'm not so sure that it is so easy to do what you say in neonate primary procedure compare with secondary procedure. I mean, a 3-year-old patient with the with a posterior intrusion, and you re-operate after primary thoracoscopic repair. So I'm not so sure that when you say it is easier, primary procedure is easier for everyone.
Okay. Again, you need a good collaboration with both your ENT who is performing the bronchoscope and your anesthesiologist. So you have this 3-valve adjustment on your tube, and you can easily introduce this bronchoscope inside. And when you are ready with your suture, you ask to do the flexible bronchoscope. We can also look with them at the other screen where they are introducing the flexible bronchoscope. And we can see by pushing on it where we are, and then take a hitch. And then immediately when we think, okay, it's okay, they pull out the flexible bronchoscope and they continue their ventilation. If at some point you need more time, okay, you just wait, you reventilate the patient until it's stable, and then you go in again and then take your hitch, and well, that way you can place your sutures. You need a good collaboration, but it's very well doable.
David, it's possible to share again your presentation, because you show a wonderful picture. There is the schematic of the tracheopathy during the thoracoscopic, because if it's possible, I want you show exactly what is the ideal place to put the stitch. It's possible to...
I'm going to share the screen again. Let me see this one.
Yes, just arrived, yes. Because it's a wonderful picture, and if it's possible to explain, well, okay, this is okay.
Yeah.
Because during the thoracoscopic correction of esophageal atresia, what is the best side to put this to stitch?
Actually, when you are ready for start putting in your sutures, and then again, like you see in this scheme here, you have mobilized it sufficiently to make your anastomosis, and then you put in your bronchoscope, your flexible bronchoscope, and the bronchoscope will tell you where the most collapse is. And by pushing on this area of the posterior membrane with your instrument, with the bronchoscope can confirm that you are in the right spot. And then you place your suture at that place, and you fix it against the prevertebral fascia. And then again, you come in again with your bronchoscope and see if that is sufficient, or that you need another stitch, either more proximal or more distal to this first stitch. And for instance, like I said, the 2 patients that we had that had only minimal malacia of intrusion of the posterior membrane, but after cutting the fistula, had a huge amount of collapse. We placed the suture near the fistula closure and lift that up and see what happens. So you have to feel a bit and look a bit and see what is optimal in correcting this intrusion, so it will prevent future incidents.
Thank you very much, David, for your answer. Now we have other questions for the audience? Okay, please. Yes, please. Professor Varela, please.
Thanks, Mario. Just one comment and some questions to David. I'm not afraid to stitch all the wall with the proline, so to get a big bite in the posterior wall if I do it. Because if you go through the wall with the proline, probably nothing will happen, because we do a lot of tracheal surgery and we put the stitches around the wall and nothing happened. Sometimes you can get a granuloma, of course, but that's very infrequent to see. And that's why Russell Jennings likes to use proline instead PDS, because if you go with the PDS through the wall, you can get more reaction than proline. That's just a comment. I would like to know if you are agree, David, because probably sometimes you go through the wall and I will not remove that stitch. I think that is okay. Well, and second, that this is a question to David. So we are doing this procedure, okay? But I have seen a wide spectrum of the technique. I'm talking about a procedure in a child that is 4 years old, not in the first step, no? So a redo for tracheomalacia. So I have seen Russell Jennings. I have been with him several times. He likes to stitch the trachea in 2 lines with 8 stitches in each line. Each stitch is U-shape. So it's a long surgery. It's a nice surgery, but I'm talking about more than 10 stitches, probably 15 stitches. So that's absolutely different if we see some thoracoscopic posterior tracheopexy, because we do some thoracoscopic and we put 3-4 stitches, no more. So what do you think about that? So I will look in different surgeries really, because we are not doing the same. It's not easy to put 18 stitches or 15 in a thoracoscopic way.
I agree. I always say, keep surgery as simple as possible, because the more you do, the more complications you can cause. So if you can deal with the problem of tracheomalacia causing incidents by 1 suture, just do 1 suture and no more. If you need 2 or 3. So I think, we all know Jennings. He's a great guy. He's a great surgeon, but I wouldn't do it that much. He does them open, I think, always. And then again, it may be different. He also sometimes he uses to displace the aorta. So he does many different techniques. I'm a simple surgeon, and I try to keep it simple, just enough to deal with the problem that you are more or less sure that you will not get such a collapse that you will have incident. Regarding the through suture, again, yes, we use non-resorbable sutures because it needs to stay there. We've had a granuloma in the earlier stage in 1 occasion, and that is the reason why we try to avoid it. I mean, I know that Jennings also does the intraoperative bronchoscopies and see that he's not going through and through. So, and as long as that is possible, why not? I mean, yes, you can go through and through, and you may get a granuloma, and you may cut it out later. But if you can avoid it, it's easier. You don't need to go back later for your granuloma. So again, we try to do it as meticulously as is possible. And again, it's a good collaboration between our ENT surgeons and the anesthesiologist, because the collaboration is very important. You have to know when to stop, when to wait, when to go back. But as it goes very well. And I must say, since we have started using this technique, the amount of patients that come to us with life-threatening events, bruise, has decreased massively. So I think it's, and also, and that's thinking, I think for Professor Sacco, interesting that the respiratory tract infections due to the excessive, I call it movement of the posterior membrane, is also greatly reduced by fixing it against the peripheral fascia. And we all know that all these patients with Esophageal atresia, they tend to have many airway infections in the first year of life. So if you can reduce this number of airway infections, I think that's also a benefit.
Great, thanks.
Thank you very much, David. Thank you very much, Patrizio. There is a last question, Michele Torre.
Yes, in part was already questioned by Patrizio, because I also wanted to ask if 2 stitches given in thoracoscopy at the time of the primary repair could be comparable to I don't know, open or robotic tracheopexy with, I don't know, 10 stitches. But I have another question. Do you think, David, that this primary tracheopexy could reduce also the incidence of recurrent fistula? And do you put also a stitch between the site of the previous fistula to the spine to reduce the possibility of recurrent fistula, or not?
Okay. First of all, the most important stitch is the stitch where you see the greatest collapse. But then again, we usually put in 2 or 3 stitches, and we go up to the site of the fistula, because then you also are secure that by cutting the fistula, you will not get an intrusion later on. So usually the intrusion is proximal from the fistula. So to put in 2 or 3 stitches from the maximum point right up to the fistula. And again, some people put in a lot of stitches. I think just you need to do as much as is possible to prevent future complications.
Okay, thank you very much. Now, Adrian Bianchi is ready, and to speak about thoracic reconstruction, his experience from neonatal surgery. Please, Adrian. Okay. Thank you. We see well your laptop? Yes.
Okay. Fine. Well, first of all, thank you very much. This has been a very interesting experience for me. I have not a great experience with trachea, a little bit more with esophagus, but through my life I have formed some views, and also I have some ideas and concepts which I would like to put before all of you, in the hope that they may help you as they helped me, but also for your criticism. So that's very important to me. So I have called this tracheal reconstruction for situations that present perhaps more commonly to the neonatal surgeon. Other speakers, Michele and others, have spoken already about laryngeal cleft and such like, and we would normally, having made the diagnosis, involve the ENT surgeon, and then we never see the patient again. But I have put it there to say that it is very important in the care of these children, before you do anything, that you start with an endoscopy and you look for you actually look at the larynx and the back of the larynx. Otherwise, you will miss the cleft. And I have seen that happen quite often because people pass the scope and then just look for the fistula and come away and never bother again. So I will not say any more about that. Now, I have had only one child who presented with subglottic stenosis. And for other type cases, they usually go straight to the ENT surgeon and we don't see them. But this one child also had esophageal atresia, which is why he came to us, and he was having quite some difficulty breathing, and it was only just possible to pass an endotracheal tube. So we, in order to allow the repair of the fistula and the esophagus, we did a tracheostomy at the time and proceeded to do a repair of the esophagus in the usual manner. But it passed through my mind at the time that it would be interesting to consider whether, instead of doing a tracheostomy, whether there was a method, a technique, which we could use to do a primary reconstruction without a tracheostomy, using the trachea, the tissue from the trachea. And I had with me at the time a colleague from Norway called Steinhaugen, who was interested to do some experimental work. This was in I think around about 1988 or so, which we then published. The work was on Sprague Dawley white rats, which are very tame. And what was done was to give peritoneal anesthesia. The rat was not intubated. And then we opened the neck to expose the trachea. The trachea is about 2 to 3 millimeters in diameter in these animals. And then we removed, to try to simulate a subglottic stenosis. And what we had in mind, we removed the posterior 2/3 of the cricoid cartilage, leaving only a small bit anteriorly, and then the first ring and the anterior 1/3 of the third and the fourth rings on the trachea. So we had then a trachea with a flap of viable wall, which was supported with cartilage for 2/3 of the way round, which we then advanced upwards and anastomosed back again, replacing that section, which would have been the stenotic bit. So we did 30 animals, and 2 died post-operatively from, I can't remember what it was, but I think respiratory infection type causes. But the rest survived, and then we sacrificed them at 8 weeks after the surgery, and we found that everything had healed very well with a good open pathway through the repaired trachea. So it seemed like there was a possible way to treat our child with subglottic stenosis, even though he had a tracheostomy, with this sort of management, and hopefully to get rid of the tracheostomy. But the idea was to have a primary repair without tracheostomy for subglottic stenosis. Then we had tragedy. The baby was on the ward awaiting surgery, and for various difficult reasons in the hospital and nursing staff numbers. Anyway, the endotracheal tube fell out, the tracheostomy tube fell out and the baby died. So we didn't have the opportunity to apply the experimental technique to the clinical situation. But I put it there in case it stimulates interest and for your comments. it passed through my mind, and again, I have no clinical cases, that it may be the same idea might be applicable to the short tracheal stenosis situation, or through areas of trachea maybe which have no cartilage, where if they're not too long, one might be able to advance the cartilaginous trachea, removing the bit in between. So I will be interested in comments from you, my colleagues, the experts. More commonly, the neonatal surgeon sees esophageal atresia, as you have seen. I won't go into details, but just to say that we tend to refer always to esophageal atresia, and we tend not to give so much regard to the trachea. Everyone concentrates on the esophagus, not so much on the trachea. Today, thankfully, we are concentrating a little more. But the average surgeon always wants to talk about how to repair the esophagus. As has been said, I am in full agreement that I used a rigid tracheoscope. It's very important. You can see the back of the larynx. You must see it. You must look for it. You must think of it, and not just go straight down for the fistula. Here you see a fistula at the carina. You see that you will see later that. Well, let's carry on. Here it was so big that we went through it to look at the lower pouch of the esophagus, out of interest more than anything else. You see that the cardia is closed, it's intact, the esophagus is nice and wide, and it functions like normal. Everyone says it's dysfunctional. You see cartilages that are weak, you see posterior protrusion, and you see tendency for closure. And that's always in that section, the intrathoracic section around the fistula zone. Then as you come back, you can look very carefully at the back wall to look for upper pouch fistulae, and again on the way out to ensure that you have not missed a cleft. If you do not think of it, you will not find it. So I believe very strongly that tracheoscopy preoperatively with spontaneous breathing gives you the best diagnostic conditions. And it must be done before you do anything, because what you do will be determined by what you find. So if you see that situation, we have just been talking about ways of posterior tracheal weakness. In England, we have a saying which says there are many different ways to kill a cat. So that was one way. I, in my time, had developed a different idea as to how best to manage this, going for what I believe to be its root cause, which is related to the esophagus. So the management of the esophageal atresia is division of the TOF and reconstruction of the esophagus. That's the concept. And very often, many end up with some degree of stenosis. In this case was fibrotic stenosis, but you see the dilatation, which is primary, not secondary to the stenosis of the upper pouch, which allows liquids to pass, but then with solids swells up, causes major protrusion into the back of the trachea, occluding its lumen, quite apart from not allowing the child to eat. And here is another situation. There is no fibrosis here, but look how big and wide and the upper pouch is. And this is a space-occupying lesion when it is filled with fluid, with food, when the baby tries to eat, which bulges into the back of the trachea and then causes tracheal occlusion and the apneic so-called dying episodes that we often see. When I was in my young days at All the Hay Children's Hospital in Liverpool, we used to be told that if a baby has this sort of dying episode where they have occlusion, you had to grab them by their legs, turn them upside down, and bang them on the back so that anything that was in the esophagus fell out. It may or may not be the right thing to do, but what it tells you is that what is in the esophagus is causing the compression of the trachea. I call this tracheal occlusion from a situation of pseudo tracheomalacia, not real tracheomalacia. It's a question of how you interpret things. But essentially, I think we are in agreement that there is weakness in the posterior wall, as well as in the cartilages. And then, following the impact of the usual type of surgery, many insist on an anastomosis. They mobilize fully the lower pouch, denervate it, and then say that is dysfunctional. And in doing so, often pulling it upwards, you end up with a hiatus hernia and lots of reflux as well. Very important in this context to consider what is the impact of our surgery, not only on the esophagus, but also what we do with the esophagus, how it impacts on the trachea as well. So the trachea has congenital difficulties, but what we do also has an impact on the situation in relation to the trachea post-operatively and how it will perform. Okay, so my approach, and as I say, there are several ways to do things, and my solution, based on what I was seeing, was to say, this is an esophagus that is far, far too large, creating an anastomosis of big to small, even if there is not fibrosis, creates a funnel effect with collection of food, particularly solids, which then pushes into the back of the trachea and obstructs it. So why do we not try to tailor this esophagus down to normal proportion and open up somewhat the lower esophagus so that there is an esophagus of more uniform diameter? And I do that, as I mentioned before in other situations, by taking a large, wide flap out of the upper pouch, full thickness, fully vascularized, turn it down, open the fistula and the lower pouch and insert it so that I have a wide anastomosis, but essentially gives me a narrower, more uniform esophagus with free transit, which then does not bulge into the back of the trachea. And sometimes it's possible even to use some of it to elongate a little bit, but let's not go into that today. Okay, so the way I see things, or did when I was working, was that in the context of esophageal atresia, we had this pseudo-tracheomalacia which related to a dilated upper esophagus. So why not deal with what I believed to be the primary cause of the problem? And maybe today, following David's presentation, I would consider even supplementing my management with posterior tracheal sutures as well. But in that time, this is what I believed. Then we have the real tracheomalacia, which is where there are weak cartilages which collapse, and in association with the weak membranous part, then lead to virtual total occlusion of the trachea. And you see here some of the situation. There were better pictures in my colleagues' presentations. There are several techniques described, and amongst which even a long-term tracheostomy. Others involved cartilaginous support, prosthetic materials placed on the trachea, and even intraluminal stents, which did not make sense to me, and I disliked them entirely. Then I used to speak at that time a lot with Louis Spitz at Great Ormond Street, and he used to say, aortopexy, aortopexy, beautiful procedure. And I am a coward, you see. I do not like to find myself in trouble, especially in the operating theater. So I said to Louis, what happens if the suture in your aorta tears out when you start to pull on it? And he said to me, well, you have to put it deep enough. And I said, yes, but what happens if it tears out? He said, there's a bloody mess. And I don't like a bloody mess, so I don't like aortopexy, and I have never done one. Oops, don't know what happened then. Sorry. And I have never done an aortopexy. I prefer the tracheopexy, the anterior tracheopexy. You can combine with aortopexy if you really want to, but I don't like to touch the aorta if I can help it. So for me, my experience, small as it is, has been with tracheopexy. And then I will speak about cartilage ring grafts in a moment. So approaches can be by thoracotomy, but I much prefer the cervical approach because it leaves a more aesthetic scar, which is also transmanubrial, as you see here, and you've seen in other presentations. The manubrium is split and it brings you into the anterior mediastinum, your extrapleural, and there is the thymus, and you remove a good proportion, about 3/4 of the thymus. I like to leave thymus because I believe that it has a good function immunologically, so I like to leave some. But essentially, this approach gives you excellent access after you remove the thymus to all of the big structures, including the arch of the aorta, if that still interests you, the whole of the trachea, all the way down to the carina and the bronchi. Of course, you can also see the recurrent laryngeals, which you keep well away from, but at least you can identify them and protect them. And then you place sutures into the anterior and lateral wall of the trachea, and you bring them through the manubrium, and then you close the manubrium, and under endoscopy, tracheoscopy control, you start to tie the sutures, and you can see the trachea moving into the space where the thymus was behind the manubrium, and the lumen being opened up and supported. So that is how I perform tracheopexy. And then in November 1988, I had a really difficult situation for me at the time, where this child was born at full term, 3.5 kilos in weight, with esophageal atresia and fistula of the usual variety, but she could not breathe. And so she was intubated immediately, and everything cleared up. She was perfectly fine. There were no lung problems of any sort. She required minimal oxygenation, if anything, but without the tube in place, she could not breathe. So we endoscoped her and such like, and looked at things carefully, and we noted that there were no cartilaginous rings at all. And previous speakers have spoken about the sort of esophageal trachea, if you like. And this is what we had. We had the cricoid, and we had the carina, and no cartilage at all. And I had absolutely no idea what to do with this. So we left her intubated. We got rid of, in the usual manner, the atresia and the TOF, and took her back to the ward, intubated. And I said to the mother, I don't know what to do. I need to consult. But in the meantime, I think we are going to have to do a tracheostomy for a long period of time. And the mother said to me, I will not give you permission ever. I have a child who is neurologically impaired at home. I have a husband severely depressed, crying. I have to go out to work. You cannot give me a child with a tracheostomy. Do something else. So I didn't know what to do. So when I don't know what to do, I pray. Whether I am a believer or not is another matter, but I pray. And I prayed to the great God up there in heaven, who created man and created the trachea. And I say, inspire me, tell me what to do. And here is the fresco of Michelangelo from the Sistine Chapel of the creation of Adam. And all of a sudden in my mind comes the creation of Eve. And God, the first anesthetist, put Adam to sleep and took from Adam a rib and cartilage and made Eve. Now, I am not God, and I don't know how to make a woman from a rib. I know I have a daughter. It was very enjoyable making her, but not from a rib. But anyway, there was this idea in my head, and I thought, okay, what I will do is I will take slivers of cartilage from the costal margin, and I will shape them in the form of 3/4 rings that will fit around the trachea, weaken it on the front to allow me to bend it, but leave it springy so that it has a tendency to open out and support the trachea. And then I will place them on the trachea, tied 1 ring, 2 rings, 3 rings, 4 rings. This is in the cervical portion, extending all the way down until we put 11 costal cartilage grafts onto the trachea. And so here is the child after she has healed up. A few weeks later, as you can see, there is a cervical incision. There is 1 incision. There's a thoracotomy, which in those days was a longitudinal incision. There is the incision for the grafts, harvesting on one side and on the other. And you see she's breathing well. She has not got a tracheostomy. So this was a way of doing a repair, a primary repair, without tracheostomy. Here she is growing. She suffered greatly from bronchomalacia, which we had not noticed before, but became more marked once the trachea was stable. Sorry. And here she is again, and here she is at 28 years of age in 2015. So I put that to you as an interesting case, with a technique which helped me out of a difficult situation. Maybe it will help someone else in the future. At that time, we had 4 other patients who appeared over the next couple of years who had problems. They were referred, in fact, by ENT surgeons because they had tracheostomies, and normally they just take the tube out and the tracheostomy closes. But in these cases, the trachea would collapse and they could not achieve closure. They would have to place the tube again. So I thought, okay, we'll see if we can help in the similar manner. So operation 1 was to put the patient to sleep, take the tube out, close the trachea, leaving and the skin, and wake up the patient, leaving an endotracheal tube, and then go back 3-4 days later when the tissues are beginning to heal and the trachea is closed, and place costal cartilage grafts as previously. I haven't got a picture of any of those, but it's similar to this exactly. And we would put 4 grafts in that area and then close over. And that strengthened the trachea sufficiently and kept it open for them to have a good tracheostomy closure. For laryngotracheoesophageal cleft, I have never seen one. I have seen similar acquired situations where a patient had various procedures done and ended up with a long slit in the cervical thoracic region, like a very long recurrent fistula. So, but I don't have experience of the tracheoesophageal cleft. I keep in my mind just one concept, right or wrong, again for your comments. In its repair, if I cannot repair both, I would favor the trachea and then substitute the esophagus with a jejunum or a stomach or whatever else I believe to be correct. Okay, my final slide is this one. It says, you only have to ask and you shall receive. Thank you very much. Now, how do I get out of here?
Thank you very much, Adrian. And now we start the discussion. Discussion from audience.
Top side.
This question, yes?
Okay, back and on.
Okay. Oh,
Can I ask
David, please, David, please.
Thank you very much for this very impressive presentation, Adrian. These tracheal rings that you made, how did they develop over the years? Because the issue in neonates is that they are small, children are small, they have to grow to in adulthood. What happened to those tracheal rings?
You know, instead of your face, I am seeing the face of the mother who refused me permission for the tracheostomy. She said, now that you have put these rings, what is going to happen when she is 10 years, 15 years? And I said, I don't know, but you have a live baby at this time. So we'll wait and see. And so we did. And the answer is, because I endoscoped her as she grew from time to time, to make sure that there was nothing else. And the answer is that the trachea grew and the rings adapted themselves, the best way I can put it, so that they were what I would consider to be at least 3/4 the diameter of a normal trachea. So I won't say to you that I had a normal diameter trachea for the age, but it was at least 3/4 the diameter of a normal trachea. So they did grow. She is now 32 years old and does have, I still keep in touch, or they keep in touch with me, and she has no problem.
Very impressive. You nowadays have those biodegradable external stents that you can use, which are very promising. So for all of you who may have such a patient in the future, look into the literature, because there are very promising techniques. They resolve over time, but you can overcome the neonatal period up to 2-3 years without having to put in a tracheostomy. So thank you again, Adrian.
Pleasure. I like live tissues. So where I can, I like to use live own growing tissues.
Michele Torre, un commento.
Yes, congratulations, Adrian, for this amazing surgery, for this difficult case, and we will remember to pray in the difficult cases that may help. And I wanted to comment about what you asked, what you told about the tracheal resection for, and you did some sort of flap to avoid, I guess, more tension on the tracheal resection. This is a subject maybe Patricio Varela want to add something, because we have spoken often about that, about the fact that in the book of tracheal surgery, Philippe Mounier always used to tell that it's written that for the children, the length of the trachea safe for resection is 30%. Actually, we used to, and we have experienced both of more extensive tracheal resection, at least 50% of tracheal resection is possible in children with some tips, some maneuver maybe to reduce this tension. But it's I don't know if Patricio Varela wants to comment about that, but we also collected a series that I hope will be published soon. And it's a very fascinating subject, because sometimes people think that there is a limit to this, And actually, the limit is much higher than expected.
Thank you very much.
Thank you. As I said, I put the suggestion of using the flaps like that simply for your comments, because I don't have any clinical experience, and the trachea was not an area which came to me except in the context of the esophageal atresia. So yes, Patrizio, it would be nice to hear your view.
Yes,
Commento.
Patrizio. Yes, please.
Commento. Commento.
Please.
Nice word, commento. We say comentario.
Comentario.
Congrats, Adrian, for the presentation. And I would pray every day for more meetings like this. Okay, I have enjoyed a lot. Yeah, we can reset at least 50% of the trachea. We have done, yeah, but it's very special patients. But we can reset all the cervical trachea and do an anastomosis between the intrathoracic trachea and the cricoid. So we are working, we have done a manuscript with Michele and with Diana Romero from Colombia, so 3 centers. And we will publish in the next seminars in pediatric surgery. This June is coming. It's a journal with a very nice manuscript about airway. And the group from Cincinnati, they used to do something you did in your case. So they used to do a cervical slide tracheoplasty. So not for congenital ones, for acquired tracheal stenosis. So they prefer to do a slide and preserve some fibrotic tissue in order to reduce the tension. But we used to reset long segment. Is more possible in small children than older patients. No, nothing else. Congratulations. And as David said, today we are using external stents, splints, with the synthesis material or others, something like you did with the cartilages. I remember that case you showed it today. It was amazing, and it was published. It was 32 years ago. So congrats for that.
Thank you.
And the child, to see the child growing is more amazing than everything. Was amazing. And probably the trachea is growing. Is growing like when you put 2 bars or 3 bars in the chest for a NAS technique. So the chest will grow because the bars or the rings in this case are not around the tube, around the trachea or around the chest. So it can grow.
Yes, these are 3/4 rings. Can I ask David and you also, if you use prosthetic materials or absorbable, especially materials, instead of live cartilage, what you would expect in terms of support of the trachea as the cartilage, as the material is absorbed?
Usually in the in most cases where you have those tracheobronchial malacia, most of the patients overgrow. By the time they are 4 years old, the growth is such that you will not have a full collapse anymore of your trachea or your main bronchus. So this material, this biodegradable material, usually survives for 3 to 4 years before it dissolves. So by that time, you have overcome the major problem. And then they are able to maintain their own ventilation or breathing spontaneously without any support. And you prevent them for being on the ventilator for the first two years.
Thank you very much.
Yes, Patricio. Yeah. Go
Yes,
on.
Mario,
yes,
please.
yes. Please.
Yeah, just few comment about this. Yeah, the reabsorbable external stents, we think, because we don't know many about this, we think that they induce fibrotic tissue around. So they disappear by, they induce this inflammation around, and that's help to the malacia when we use in the bronchus or in the trachea. Because when we use cartilages like a graft for the airway reconstruction, if you came back later, you will not find the cartilage there. You will find fibrotic tissue most of the time. So probably the cartilage, you did a graft, you did implant in that patient, probably see if you came back to the chest, you will not find, I'm not sure, but probably you will not find cartilage. Probably you will find something like cartilage or maybe fibrotic tissue. The same when we use periosteum. So if you use periosteum for reconstructions in very special cases, the periosteum will induce something around, and probably if you came back, you will not find the periosteum. You will find fibrotic tissue. So we don't know. It's just a hypothesis.
Yeah,
I see.
Do you have any ultrasounds that can substantiate these ideas that it is being replaced by scar tissue?
Well, I think that's to Patricio rather than myself. The best I can tell you from a clinical point of view, because I didn't think to go and biopsy it, I couldn't find a justification anyway, is that if you feel the trachea that has been reconstructed, you certainly feel rings, firm rings. Now, I don't know if fibrosis, as you suggest, would give you firm rings. But, you know, I accept what you are saying. It's very interesting.
Yeah, we don't know. We don't know.
Adrian, could I come back to the esophageal proximal flap technique that you have used?
Yes.
Because we all know that all these patients suffer from dysphagia, particularly from the distal esophagus. And don't you think that this form of surgery also increases the amount of dysphagia in these patients?
Well, I can only answer you with my personal opinion. I disagree entirely with the concept that the distal pouch is dysmotile in a big way. I think it starts its life intrinsically correct, and it starts its dysmotility as a result of the surgeon who does intensive mobilization because he wants to bridge the gap. He denervates it, he pulls it up, and that's when it's a big problem. But the bigger problem, to my mind, is the big pouch that is anastomosed to the smaller distal pouch that is now refluxing as well. So my feeling is that we are concentrating on the lower pouch instead of dealing with the obvious problem of the huge pouch, which is causing us difficulty with swallowing, which is causing us anastomotic concerns, failure of propulsion because it's so wide, and pushing into the back of the trachea. So for me, the elephant in the room, as they say, is the big esophageal upper pouch. And therefore, I prefer to reduce that to normal proportions, use the tissue to open up so I don't have stenosis. And in doing so, with the free passage, I have not seen in these cases, which was my routine management now for some 50, 60 cases before I retired. In doing that, I have not seen the problems that we used to see in the past with the conventional anastomosis. Colleagues tell me that it's difficult surgery. I think the difficulties that you leave behind if you don't reduce that upper pouch are even greater for the patient, if not for the surgeon.
has been a Japanese study where they, through a gastrostomy, performed manometry in the distal esophagus prior to surgery, and they demonstrated that it was abnormal already before surgery. So I'm not sure.
I accept all that. I don't know what to make of it. I'm just putting forth views from my background experience for comment and exactly for discussion. And I appreciate your comments.
This afternoon, the role of discussant don't need, because the discussant can, no problem. Now is the last presentation. The last but not least, Girolamo Mattioli. The title is MAS in Forget Disorders. Please, Girolamo.
Grazie Mario, grazie al direttivo della Società Italiana di Chirurgia Pediatrica. Ernesto, abbiamo condiviso dei pazienti, sono tanti i pazienti condivisi e io prendo ordini dal dottor Torre in questo momento, quindi cercherò di convincerlo che lavoriamo bene. Sorry for my Italian, I was thanking the Italian Society and I was doing this. Mario, si vede la presentazione?
Sì.
Yes.
Okay, I'm going to show you how I do it. How is our practice in minimal access surgery, not minimal invasive surgery. So this is, I hope it's work. Okay, this is first how I do tracheoesophageal fistula repair and anastomosis. Endoscopic during the procedure, yes. Tracheal tube proximal to the fistula, yes. Here I show you where the foregut starts from the trachea. Step 1 is to close the fistula without entering the mucosa in order to prevent recurrence or persistence of the hole. And again, as told by Patricio, I use always Prolane 5O because endoscopically is easy to manage and is a non-reabsorbable. Then, before detaching the fistula, I prepare the pouch. I agree exactly with Adrian Bianchi. If it is too large, I do a flap as described in the literature by Adrian Bianchi and Piero Bargolan. Other question is how to use the azygous vein, and I use it, if I can, in order to create a tissue in between the esophagus and the trachea. So again, I try not to coag anything. I prefer small bleeding in order then to have a spread of monopolar or bipolar coag here, where you know exactly where the vagal nerve is, but you have also branches to the proximal pouch and to the distal pouch. And then you do your anastomosis. I don't want to focus this presentation on anastomosis. I want to discuss on upper pouch volume and posterior intrusion. I don't know if Malacha is correct. I enjoy what said Adrian Bianchi about dilation of the proximal pouch and intrusion on the back wall of the trachea. And then you do your anastomosis in the best way you want. You can see here the arch of the azygous vein in between the esophagus and the trachea. I don't know if it does create any clinical problem. We follow the patient, and I don't believe that this is a cause of dysphagia. But this is a good way to keep the anastomosis far from the diverticula, the foregut, in order to prevent recurrence. This is what I think, in my hands, a good practice to prepare to treat primary TF in neonatal age. I don't have experience on posterior tracheopexy as described by David in primary procedure. Now I'm going to focus on the other two problems, that is a persistence of foregut, or you can call tracheal diverticula, and the other problem is malacia or intrusion. I don't know exactly. Our aim is to prevent sacrifice of the esophagus because of many procedures, because of failure. You see here that esophagectomy because of ischemia of the esophagus. And this is what we don't want to speak about today. So I don't want to speak about it. So I will focus on tracheal diverticula or remnant of the foregut and posterior intrusion. I speak about diverticular remnant of the foregut. You see, this is a long segment of the primary foregut or TEF or the fistula. And as David said, after primary procedure, you have more adhesions. But we know that after thoracoscopic approach, adhesion are not so big problem as in open one. You see here, why you have a remnant of the TEF, why you have a remnant of the foregut, because you don't fix the diverticula, the fistula, close to the trachea. Someone says, open the diverticula, open the trachea and fix it. Thoracoscopically, if you open the trachea, you have a lot of fog or fluids in front of the telescope, so it's very difficult to close it. So this is an example of a remnant. I don't want to stress it more, and you see where you put your sutures very close. Question, can we use the robot in such problem? Is it better to use a robot in the chest for diverticula? Yes, our answer is yes. Also in a very low way. You see here the thoracotomy, axillary thoracotomy, and you see here the port position. They are 8 millimeter. Yes, they are very large. So I let you see the, yes, it's very invasive when you think about a 3 millimeter port, but they are less invasive compared with recurrent thoracotomy after TF repair. So you see here, you need endoscopy in the same time you are looking for the diverticula, and this is a post-open TF repair with a long remnant of the foregut, and I let you see the step of the procedure. Yes, we are using a monopolar hook. It's not correct, probably. It is better to use local energy like bipolar. You see here we have bipolar, but the hook works very, very well. So we use a very low power. We use a very fast coag, but we have to see very well the difference between open and minimal access surgery is that we have to see. We cannot touch, but we see. So we use probably more energy power device in order to see better. And then you close to the trachea the hole. Again, you need inside someone who see if you enter in the mucosa. As Patricio said, we can enter in the mucosa with proline. I don't know. I never want it happen. So when someone see inside and I enter in the mucosa, I put it out and I keep it again outside the mucosa plane. So this is what I enjoy to do when I close the tracheal wall after diverticular remnant. Difficult cases, this is a post-gastric pull-up in the back wall of the sternum and cardiac failure. So he had a lot of problems. This is the diverticula. He had the stomach on the right side, and you see this is the diverticula. This is the diverticula. So this is the diverticula in the upper part of the aortic arch. So we decide, Michele Torre decide to to reach the diverticulum on the left side. So left side is a primary procedure, right side is posterior failure and Gaussian pull-up. You see this is a subclavian, a vertebral vein, artery, pardon, a vertebral artery on the left side. If you know, the diameter of the instrument is, the tip is 2 millimeters. This is 1 millimeter, this is 2 millimeter. So we are working in a 2 centimeter space in length and 1 centimeter space in depth. And you see here something is moving. I cannot say what is this here in the back wall of the aorta or the supraortic arteries. So I cannot say what is this. It's moving, and the anesthesiologist and the pulmonologist, Olivier Rossacco, let me see where I am. I don't know where I am. You see the light. Adrian Bianchi said to pray, and we see the light. Sometimes we see the light without praying, but I'm joking, obviously. So the endoscopist, pulmonologist, anesthesiologist, all the staff help Michele Torre to reach the target. Again, I'm using here monopolar hook. So yes, we have spread of energy, electric power around a very nervated area. But again, technology is better this one than others. So I can grab the tissue, keep it up, see what is, and then coact. Again, open the trachea and not leave any remnant. So I look for the wall, I ask to the anesthesiologist or pulmonologist to let me see exactly where I am, and then I open. In this case, it's very difficult. I open the mucosa and see where I am. You see here the light is over there, and I go a little faster. You see the mucosa. Here is the submucosa plane, and then we open it and see where we are inside the trachea, and we decide how to fix it. Collaboration with anesthesiologist is absolutely mandatory. So we have a balloon in the trachea, so anesthesiologists do not inflate this area because the balloon is exactly positioned where you can see the neck of the diverticula. You see here is the balloon in the neck of the diverticula, so we can see very well the mucosa plane, the trachea wall, and we can fix this area very close to the trachea wall. The pulmonologists don't want bag around the trachea because the bag around the trachea is a collector of bacteria and chronic cough and chronic infection. So when we do diverticula of the trachea and we fix the trachea wall, not we ligate the diverticula. We have to close the neck of the diverticula. So we need exactly to see where we are, and then we can do it. Is endoscopic surgery better than open approach? For me is yes. Is the robotic approach better than standard thoracoscopy? For me is yes. So minimal access surgery means that we use 4 8mm ports because we can work inside in a safer way than in thoracoscopic approach we're using 3mm instrument. You see the balloon is exactly where we want. We go very close to the balloon, and then we fix the trachea wall without any new bag due to our impossibility to suture correctly. You see the space where we work. The second problem we face with the tracheoesophageal atresia and fistula is the tracheomalacia or posterior intrusion. I think, as Olivier Rossacco said, that the anterior approach need thymus removal and fixation of the trachea through the aorta to the sternum. But we know also that these patients need cardiovascular surgery. So I think that it is better to keep the anterior mediastinum free from any procedure if we can. So Michele Torre, after his experience in Boston with Jennings, we decided to start with this program, and Olivier Rosacco, who is the clinician who follow these patients, decide in a prospective control trial with ethical committee involvement to start to follow the patient. You see here, we are in the back wall here. This is a prone position of the patient, and you see the intrusion or the movement during breathing. Here you see the movements. And I'm not sure that I'm able to do this procedure in the neonate in a 2 kilogram with the primary procedure for TEF repair, because as Michele Torres said, we have to put 2 rows of sutures, and more or less we have to keep in 15 sutures in 2 rows. And we want to go from the neck, near the neck, to the bronchus. So I think it's very tiring procedure. And so I think in my experience, I prefer an infant or older more than a neonate. Here, when we separate the esophagus from the trachea, we use energy sealing device without monopolar coag. So yes, here we don't use monopolar coag in order to prevent neurological impairment due to electric power. So you see here, where do we put the suture? Pulmonologists say, where do we put the suture? The tracheal tube must be very proximal, quite in the larynx, and the endoscopist let we know exactly where to put the suture. In other case, you free the esophagus from the trachea, you reach the place where the fistula was, and you see the suture very well. You see here the suture line in the trachea, and here you need to cut to free the esophagus from the trachea because there is adhesion after TF repair, anastomosis, or fistula ligation, and then you have to reach the neck, the area of the neck. You see light. This is the bronchus, not the trachea, and then you separate. It's not easy. David van der Zee said it's not easy. True, it's not easy, but it's larger the space more than in infant, more than in neonate. So this is not clean. So I let you see the more elegant one. This is another case. We did many cases, thanks to Michele Torre, after thoracotomy, after TF repair, poor position, 3 years, 18 kilograms, which is the limits in size. I don't know. We are going down. We are going in infants in the chest, but I cannot say which are our standard. I'll let you see a non-TF patient. So this is primary tracheomalacia, and so this is a non-TF patient. So tracheopexy, posterior tracheopexy. This is obviously we have to reach the esophagus. We clean the esophagus. We free the esophagus from the trachea. You see here the back wall of the trachea. You see that cartilage here, and I don't know the other side, backward, left bronchus. So we are dissecting the esophagus until the neck and in the aorta plane. So I think that in neonate I cannot do this. You see the inlet of the chest. We reach the neck outside here, and then we decide where to put the suture. So again, the pulmonologist or anesthesiologist. In our experience, we have pulmonologists. Dr. Sacco always with us to decide the strategy. So you see the esophagus completely free. You see the trachea on the back wall. You see the spina, and then we put the suture. Never inside the mucosa plane. Which suture? I prefer Prolene. This is a non-Prolene suture. This is a multi-layer, and then we decide another suture and another suture. Now my standard is Prolene, you see here. Where you put the suture? In the 2 row in the trachea and the 2 row in the spina. Pay attention to the lymphatic structure, but with the robot, I cannot let you see very well what I see when we are in the console, because here you have a 5 millimeter telescope. In the robot console, you have 2 5 millimeter telescope, 4 millimeters telescope, and 3-dimensional. So you see very, very better than here. And then you can reach the bronchus. Here is the left bronchus, and the right bronchus obviously easier. And you fix it, 2 rows. So I think that in neonate, I cannot do this. I cannot do this, really. It's very tiring, boring. The patient is unstable. You have acidosis due to trachea ventilation not perfect. Can we do this procedure after TF repair? Yes. This is a patient who underwent 2 procedures through thoracotomy. You see adhesion, extrapleural thoracotomy, and esophageal fixing, and secondary dations and secondary procedure. Again, tracheomalacia or intrusion. I don't know the difference. You see the trachea, you see the esophagus, or imagine the trachea and the esophagus. Then you free very easily the esophagus distal from the carina, and then you stabilize the esophagus as you enjoy, and then you start your mobilization, the esophagus and the trachea proximally. I say until you see the neck inlet. You have to find the aorta plane in the back wall of the esophagus, so you are sure that you do not create problems to the aorta or supra-aortic vessel, arteries, and then you free. Bipolar, monopolar, energy sealing device. I think bipolar is the best way to free the esophagus from the trachea. You see this? This is on the left side, and this is the aortic arch, and in this area you have the vasculature arteries to the neck. Here is, you see, very gentle dissection, very anatomical. You see here, this is the left side. You can go from the right to the left. You see here the arteries, and then you free completely the esophagus, the proximal one, from the trachea. Adrian Bianchi said intrusion of the upper pouch due to dilation. This is what I believe. I do the flap if I have dilation in primary procedure. I free the proximal esophagus from the trachea, and I believe that if I move the esophagus far from the trachea, I reduce intrusion, and then the pulmonologist reduce symptoms. So again, you see very well anatomy, and then you decide where to put. You see the aorta, you see the supraortic branches, and everything is clean, and you have no bleeding at all. And again, you put. I prefer to put first the suture in the spina and after in the trachea, because sometimes you break the needle when you enter in the bone. You don't enter in the bone, but you can do it. So it can happen that break the needle. So I enjoy to start with the bone. And then you do your suture. Here, David van der Zee told me how to do a sleeping knot, and this is very useful. What can happen to the esophagus? Can become dysphagic. Yes, it can. You see the light when we put the suture, the endoscopist want to see where we are, and so we stop the light, we switch it off, and then the endoscopist can see very well where we are. And again, 2 rows, 10 sutures in 2 rows. Michele Torre asked me to put 20 sutures, 10 per row. I cannot stay in the console for so a long time, but the procedure lasts 2 hours generally. Again. And you see that tracheopexy, posterior tracheopexy is a stabilization of the posterior wall of the trachea and move the esophagus far from it. So I think it's like anterior orthopexy. We remove the thymus, and this is probably the most important thing. Again, and I'm going to close my presentation, after primary repair, after thoracotomy, we start with thoracoscopy and we move to robotic assisted thoracoscopy. And again, free esophagus from the trachea is not always easy, but robotic approach is better than thoracoscopic approach, and thoracoscopic approach is better than open approach. And then you free the esophagus from the trachea until the neck area. And you do this and try not to coag anything. It's better a little bleeding more than denervation. And then you decide how to fix the trachea. Here you can see the esophagus is moved from back to left. In the other case, we moved from back to right. So it depends on the patient. Prone position, 4 ports, and you stay there and fix it. What happened to the esophagus? We move it. We move it far from the trachea. It's like for primary anastomosis, when we put the anastomosis far from the trachea using the azygos vein, the branch of the azygos vein. And tracheomalacia, posterior tracheopexy, we move the esophagus far from the trachea and fix the trachea to the spina. Does it create dysphagia? I don't know. We had only one case who had dysphagia, and I don't know exactly about the outcome of dysphagia, but we did not reoperate. And this is last presentation every time. I'm sorry, Michele. I show you how boring is this procedure for who does not work, but decide. Michele is the chief on this program. Always closure of the fistula, extramucosal. Always outside the mucosa for primary closure, and also for tracheopexy. Create a flap in between. Yes, we use arch of the azygos. And probably posterior tracheopexy is better than anterior one. Thank you to everyone. Thank you, Michele. Thank you, Oliviero. Thank you, Mario Lima, Presidente della Società, and to all the friends. I spent in Utrecht 1 month with David van der Zee, and I was impressed about his quiet surgery. I'm not quiet. I'm very nervous, but robot helped me. Thank you very much.
Thank you, Girolamo, for your wonderful presentation. And I ask to the audience if there's question or comment.
Could I come back to the principle? Because what you do is you over almost the whole length of the posterior membrane, you perform the tracheopexy. Is it necessary? Because usually, that's why we divide it at 3 different levels, how the intrusion is, how much the percentage is, and it needs to be more than, say, 50% before we put in a stitch at that level. So that's why we restrict ourselves to maybe 2, 3, or 4 sutures and not go over the whole length of the posterior membrane, because that's not necessary. Why do more than strictly is necessary?
Can I comment as well on the same point? I agree with you, David. I don't think there is a need to fix the whole of the trachea, but only the section which is particularly weak. To my mind, there is a key principle in any procedure that you do for any condition, but especially for the children with esophageal atresia. And that is, if you are going to operate on them, do not do half an operation and, unless there's some very, very important reason why you have to stop. So for me, the best time to get rid of the problem of the weak posterior tracheal wall that then impinges when it fills up into the back of the trachea is to get rid of that which is pushing it. So the first thing is to do a good procedure on the big dilated section of esophagus. And Girolamo, your flap is too small and not long enough. So you are not doing enough tailoring of the upper esophagus. When you do that, you create space because you have reduced the diameter of the upper pouch. It does not fill anymore to compress. And the second thing is the best time to do your posterior tracheopexy, if you feel you need to do it, I would consider it now that I've seen it, is at the first operation, because you have the full dissection. You have dissected the upper pouch in order to reduce it. It is behind the dilated upper pouch that you have the weakness. So why not do everything in one instead of having to come back and redissect? So I agree with a lot of what has been said, but I want to emphasize that the best time is to do a full operation the first time round.
Thank you, Adrian. Thank you, David. Absolutely agree about the flap. Yes, it was not a flap. The video I showed, I want to stress about the azygos arch. And if you have a dilation upper pouch, I try to do a flap in primary procedure. I don't agree with David to fix the trachea in primary procedure without a clear indication. So I'm not sure to understand in the neonate 2 kilogram in intensive care unit during every day to do a so delicate procedure. So I think that in our experience, we treat only symptomatic patients after TF repair. And symptoms means that they are followed by the pulmonologist and the endoscopist, and only if you have a recurrence of symptoms, you do indication. And yes, we do a long procedure because we follow what the pulmonologists say. We don't put suture without indication, clear indication, and the localization of the floppy posterior trachea. So I agree with Adrian. Yes, we do. We try to do the flap, and I don't agree with David about primary procedure, posterior fixation with only 2 sutures. I'm not sure, but this is my opinion, not science. Thank you.
I can add to what I've stated before that, you say 2 kilograms, but we even do it in 1,500 grams or 1,200 grams. It doesn't matter.
Okay.
But the reality of life is that by whichever means you approach the patient, at whatever age and size, if you are going to repair the esophagus, you have to mobilize the upper pouch. Are we agreed on that at least? So if we've mobilized the upper pouch, we have mobilized it from the trachea, exposing the membranous trachea, which is weak. So let us sort out the esophagus whichever way we believe is correct. And for me, it is making it narrower with the flap to open up below, but whichever way you believe. But then you have your best conditions, a full dissection in the plane between the esophagus and the trachea. Use it. Now, if you find that you have great difficulty with the thoracoscopic approach, then don't do thoracoscopic approach. do open approach, because at the open approach, you certainly have a full dissection in that plane. But what is not acceptable to my mind is to do half a procedure and then have to carry on later on. So the first procedure is the time to sort out the problems. And the problems are the esophagus and the weak trachea. Why leave one and do the other? Do both. Thank you.
Can we introduce Michele into the discussion?
Yes, if I can add something, I think it's very attractive to repair, to do the posterior tracheopexy during primary repair. The problem is the technical difficulties, and maybe also that you probably will do more procedure than strictly necessary, because if you do in every case standardized treatment is also posterior tracheopexy, I'm not sure that every child will require this. To answer to David regarding the length of the trachea to be fixed, we always map the trachea with Oliviero Sacco, the pulmonologist, who tells us exactly where to fix the trachea. And very often we have actually diffuse tracheomalacia. The typical area is just above the fistula, but very often we have to go a little higher, and sometimes down to the bronchi, also on the left, on the right side. And sometimes we, in the first operations, we have performed around 10 operations, and in the first operation, we were a little more shy, and also we didn't have the robot, so we used to give only 2, 3, 4 stitches, and in some of these cases we found that it was a mild result, not very good result. In the last cases, we used to give much more stitches, always by the endoscope, guided by endoscopy, of course, but usually in our experience, it's necessary to fix a much longer tract of the trachea.
Thank you for your comment. I agree that by doing a primary posterior tracheopexy, you may tend to overtreat a number of patients. So what we say is, if you have more than 50% of collapse of the posterior wall, we will do a primary posterior tracheopexy. But the point is that by doing that, until now, and I think we've done up to 60 or 70 now, that we have seen no complications due to the fact that we have added these sutures. So it may it may take you 15 to 30 minutes extra, but it may prevent later having to come back and do a 3-4 hour procedure. So that was our initiative after doing the first few years that we went back as a secondary procedure. We found, because most patients were referred and they were they had open surgery, so you have to do extensive mobilization again, and making it much more easier in a primary procedure. That was our indication for starting this up. Regarding the extension of doing your posterior tracheopexy is, that's why we preoperatively do the tracheoscopy together with our ENTs, and we score at each level the amount of tracheomalacia, anterior, posterior, both, and only when the tracheomalacia extends up to more than 50%, Then we say, okay, this is the area where we are going to place our sutures. And that's why we usually come out with 2, 3, or 4 sutures. And again, we don't use the robot in neonates. We only do it by thoracoscopy. But thank you for your comments.
Thank you, David. And now the last comment to Patricio Varela. Ask.
Thanks, Mario. I would like to congratulate Girolamo for the presentation. Very nice videos, Girolamo. High quality videos. I have seen in one of the clips the thoracic duct. I would like to ask you, Girolamo, if you look for the thoracic duct in every case to know where it is. We have injured the thoracic duct several times in the past. Now, regarding some comments and some questions regarding the to fix or not to fix the trachea at the first procedure. I know that the group from Boston, and they see a lot of patients, they have been fixing the pouch to the spine since a long time ago. Just the pouch, the suture, no, in the fistula from the trachea to the spine. So they have done this since a long time ago, and we do in the primary repair. So we put some stitches, just 1, 2, or 3, starting with the pouch from the trachea to the spine. And maybe that's a reason why in Boston they have seen very few cases with the recurrence tracheoesophageal fistula, because they have been doing this for a long time. Yeah, that's all. And regarding again with the stitches around the wall, I think that if you use Prolene, that's a key. Huh? That's a key, Girolamo. You say that you came back if you went in because you have amazing skills, but really when we do a tracheal resection, I do always stitch the thick wall in the posterior face with the Prolene, and really nothing happened. If you came back with the scope into the trachea, you never you see very few cases with granulomas. In most of the cases, you cannot see the stitches. But if you can avoid that, and if you can go extra mucosal, obviously is nicer to see that. So, Mattioli, thanks again.
Thank you, Patricio. I answer to the question about the lymphatic duct. Yes, we had one injury and we have problems with the fluid collection in the chest. So after that case, we look for it every time and we try not to damage it. And using the robot, we have the Indocyanine and the Firefly system, optical system. So this new technology, video technology, help you in detecting everything, and is very interesting. So I think that the 80mm ports is bad, but technology is better. So this is a balance. So yes, I look for it. I try not to damage it, and it happened.
Thank you very much. I have the last comment of the discussion. Because we have also the young surgeon that listen this afternoon, the wonderful video of Girolamo of the thoracoscopic repair of esophageal atresia is correct and is fantastic to respect the azygos vein. But if in the beginning of your experience of thoracoscopic treatment of esophageal atresia, don't respect the azygos vein because it's not easy. In the second part of your experience, respect the azygos vein because it's a good protection through the anastomosis and the suture of the trachea. My role of discussant, I don't work many because the discussant is very, very important, and is very, very fine. Thank you very much all to Michele Torre, Sacco, Professor Sacco, Patricio Varela, thank you very much. Your connection from Chile is perfect, is better of the connection of Italy. David, thank you very much for your presentation. Adrian, thank you very much. And last to Mattioli that won this meeting to the trachea surgery. The next meeting is in the May, and the meeting is of the clinical case. Please contact Ernesto Leva for the clinical case, to present the clinical case. Thank you very much. I ask to Ms. Gorgoglione if it's possible to share. This is the slides for the credit of our Minister of Health. I remember that I recording this meeting, and tomorrow I put in our website. Thank you very much, and arrivederci. Bye bye.
Grazie. Ciao.
Grazie.
Bye.
Thank you.
Arrivederci. Arrivederci.
Ciao, grazie.
Ciao Adrian. Ciao, ciao.
Grazie tanto. It's a pity, Patrizio, that you cannot send Carmen Air through the Zoom.
Come to Chile. Come to Chile.
I will try.
For the next impact meeting. For the next impact meeting.
They don't let me fly at the moment.
For the next impact, we are organizing the International Airway meeting. I don't know when. I don't know when. Probably not this year because it's on December on site. But I think that we have to cancel again and again and reschedule for 2022.
It's been a pleasure meeting you again. Bye.
Thank you. Bye. Arrivederci.
Ciao, Mario.
Arrivederci.
Ciao.
Arrivederci.
Thank you.